हेलो उनके वो सब अच्छा चलो दे बिस्मिल्लाहिर्रहमानिर्रहीम so today we are going to study the concepts of polytrauma management or ATLS, that is advanced trauma life support. I'm Dr. ASKARI. I'm an FCPS orthopedic surgery and a fellow of trauma from Germany, also a fellow of Ponseti International Pakistan. Here I'm serving as an assistant professor of orthopedics at Dow University of Health Sciences, Dow International Medical College. So basically, polytrauma represents the major killing factor in young people less than 45 years of age. Polytrauma occurs mostly because of reckless driving all over the world. It can be motor vehicle versus pedestrian, motor vehicle versus motor vehicle, or some bike accidents altogether apply for this. Patient outcome in polytrauma is directly due to time of interval from injury to properly delivered definite care. So the concept of saving a patient in a polytrauma depends on the time lapse from the point in time when the injury is occurred to the start of the definite care. So the more the time lapse, the less the chances of the patient to survive. Trauma-related mortality has three related causes basically. So whenever there's a trauma, either there is immediate mortality at the action site, like if the aorta is ruptured of the patient, or the brain stem is ruptured, or decapitative injury. All these things just stop the airway, breathing, and circulation of the patient then and there, and the patient dies on the spot. For this, we cannot do anything as for now we are speaking. The early mortality, which is a golden hour, where the basic concept is to bring the patient to a definite care within the first golden hour. The first golden hour, the patient who reaches hospital within the first golden hour has the maximum chances of survival. And the mortality during that time usually occurs because of the compromised airway or tension pneumothorax and the hemorrhagic shock. Late mortality, which occurs after 2 to 3 days or maybe weeks later on after the trauma, includes septic complications, which can lead to multi-organ failure and a cerebral edema. The application of advanced trauma life support protocols since 1990 have reduced the mortality rate from polytrauma from 40% in 1970 to 10% in 2000. So as the polytrauma and the management in advanced trauma life support is increasing, the mortality from the polytrauma is decreasing. Optimization of preclinical transportation time to appropriate hospital, and not any hospital has played a major role in decreasing mortality. So there is now a concept of trauma centers, which are level 1, level 2, and level 3. So these are appropriate hospitals to deal with trauma, because to deal with trauma you have to deal with many things which not every hospital can deal with. So they are dedicated areas and hospitals which only deal with trauma and are specialized in trauma care patients. You can see a picture of a helicopter landing on a surface on a roof of a trauma center, from where the patient is transported to the treatment facility. The concept of damage control surgery rather than total care surgery involving definite fixation of long bones requiring prolonged surgery in a physiologically unstable situation prevents the second hit to the patient. So usually previously it used to be thought that as soon as the patient has come and he or she is suffering from multiple orthopedic injuries, we have to go and fix all the bones, so that as early you fix the bones, the patient gets well. But that concept has totally changed. Now the concept of damage control surgery is there. The damage control surgery came out because initially you used to fix everything and every bone of the patient, but then the patient used to deteriorate within the week, despite of having optimum surgeries performed. So the basic concept of it now lies in the damage control surgery, because in damage control surgery you just do the minimum possible thing, so that the effect of the surgery, which is also known as the second hit. The first hit is the trauma itself, and the second hit is when you operate on a patient, there's a stress to the body. You give the stress to the body, which is already under stress because of the trauma. So the second hit, the patient is very difficult to recover from that. So early restoration of the lethal triad, the death in the early time of the trauma has a lethal triad, which includes the metabolic acidosis, the hypothermia, and coagulopathy, and you have to control it or treat it before you go for any definite physicians or treatment of the patient. These are the primary goals in survival of the patient. The preclinical management. So the trauma care starts before the patient enters the hospital. The main aims of the preclinical management are airway maintenance. We have to control the external bleeding, any bleeding which is occurring at the spot of the injury. The fluid resuscitation, because of the bleeding, the patient is losing blood and dropping pressure. So we have to resuscitate by fluid. Immobilization of spine is very important, because if the spine is moving here and there, it can transact the cord and the patient can end up in permanent paralysis. And immediate transportation to the upper hospital. The thing you have to transport it as early as possible, the golden hour period. Extrication of a trapped victim is of secondary priority to securing airway protection, definitely, because to extricate the patient, you can damage the patient's airway, breathing, and circulation. So before you remove the patient from the harm's way, you have to secure the airway and also to protect the spine. Soft tissue wounds and open wounds need to be documented and covered with sterile dressings, definitely, at the, so that can be communicated well to the doctor present in the hospital. In pelvic ring fractures, the internal rotation of the thighs and stabilization it with binder controls sigmoid retropelvic. So pelvic ring, when there is a pelvis gets fractured and it opens up, so there is a lot of bleeding, internal bleeding occurs. So if you stabilize the pelvis by simple pelvic binder, you can stop the internal bleeding. All injuries and the condition of the patients need to be communicated beforehand to the receiving doctor. So communication is very important. As when you are transferring the patient from the injury site to the trauma care, during that period, you have to communicate everything so that the team there is already prepared for this. The initial assessment and management. The aim of this initial assessment is to survival of the trauma patient. That is airway maintenance and cervical spine stability, breathing and ventilation, circulation and hemorrhagic control, disability, brief neurological evaluation, exposure with environmental control. So this is the classical teaching of airway, breathing, circulation, disability, and exposure. That is A, B, C, D, E. The initial assessment lies in your A, B, C, D, E. So this is basically a trauma center where the patient trauma care area where the patient is brought and evaluated at the time. This is the patient being evaluated. The dressing is being removed. The trauma, all the fracture areas are being documented over there. So airway maintenance and cervical spine stability. Endotracheal intubation is the gold standard for airway maintenance of the patient. If the endotracheal intubation cannot be done, there is cricothyroidectomy, where you pierce the cricoid process through which you enter the trachea and make a approach for the airway of the patient. Usually, it is recommended to give 4 to 10 liters per minute of oxygen to all the trauma patients, regardless of the event the patient is in. Breathing and ventilation. So the main important thing is rule out tension pneumothorax, because tension pneumothorax is definitely a life-threatening condition. And how you remove the tension pneumothorax? And tension pneumothorax, you insert a wide bore needle in the second intercostal space in the mid-clavicular line. Okay, so when you insert the wide bore needle in the second intercostal space, the tension pneumothorax converts into the normal pneumothorax. And then for removing the normal pneumothorax, you just place the chest tube in the fourth and fifth intercostal in the mid-axillary line. So then the pneumothorax is also removed. So it is mandatory in the intubated rib fracture patient, polytrauma patient, to pass the chest tube, because the positive airway pressure definitely causes the pneumothorax, and you have to pass the chest tube even prophylactically for this. Flail chest and massive pneumothorax and open pneumothorax are also life-threatening conditions in chest trauma. The circulation and hemorrhagic control, windows to microcirculation. So how you assess the microcirculation? There is no definite instrument we have to control to check the microcirculation in every organ of the body. So the criteria we take to check the microcirculation are the level of consciousness and mental status. It shows the adequate perfusion of the brain. Peripheral circulations, that the limbs, you can see the capillary refill over there, and the renal perfusion. The renal perfusion is found out by checking the urine output of the patient, which should be at least more than 0.5 ml per kg per hour. If it is less than that, then the kidneys are not being perfused and have the condition of getting renal shutdown. So the body has the capability to compensate, and the blood loss of up to 30% of the body can be masked completely. You can have complete normal vitals even after the patient has lost about 30% of the blood, because the body is itself recapitulating from the trauma. So the serum lactate levels are also indication. Less than 2 millimole per liter is normal, but if the serum lactate levels are greater than 2 millimole per liter for the next 48 hours, then there is a mortality chance of about 85%, because the serum lactate level definitely shows the microperfusion or microcirculation in the body. Screening for bleeding. Internal bleeding can be seen by FAST, which is also called as focused assessment sonography of trauma patient. So when you do FAST, you check the abdomen and the chest, and that there are cavities or hollow viscous areas which are bleeding, or there is some collection over there. You also get to have an X-ray chest and pelvis also done. Disability. The disability brief neurological evaluation, the Glasgow Scale GCS. You have to assess the neurological examination by checking the Glasgow Scale, which is, if it is 14 to 15, there is a mild injury of the brain. If moderate is 9 to 13, and severe injury indicates the GCS of about 3 to 8. The patients with GCS less than 13, that is mild injury, should be admitted, and CT scan brain should be done to rule out any concussion / any other injury of the patient. Exposure with environmental control. Okay, so you have to expose the patient completely. You have to see the patient, the 360 degrees of the patient, from head to toe, from anterior to posterior, to lateral to medial, to every organ, to every armpit. Even you have to see even the back. So every trauma patient should be completely undressed for thorough inspection and examination. And log roll maneuver is mandatory in all trauma patients. All trauma patients must be checked of their spine, because sometimes the spine injuries or the back injuries are missed, and they can play a pivotal role in the survival of the patient or otherwise. So the damage control strategy. What is the damage control strategy? We have briefly discussed earlier. The classical orthopedic concept of early total care is obsolete now. So as we have already, I have already told you that to completely fix every bone early in the course of the patient's trauma is now obsolete. You have to first control the damage, control the trauma, and then when the patient is fine, the patient is recapitulating, the patient is improving, then you can definitely control the damage. Then you can go for the definite fixations. So damage control strategy includes, there are many things which you have to do immediately, which include decompression of the body cavities, the control of exsanguinating hemorrhage, decompression. Okay, we will come back to this. Okay, and okay, sir. And now the secondary survey. First we also touch the second survey, then we'll go for the day by day progress of the trauma patient. The secondary survey only begins after you have completed the resuscitation of the patient through A, B, C, D, E. When you have gone through the A, B, C, D, E, then you go for the secondary survey. The A doesn't come before B, doesn't come. A comes before B, comes before C, comes before D, comes before E. You cannot skip this sequence. You cannot altogether ignore it, because this is the primary thing in the survival of the patient. It has to be a detailed head-to-toe examination. Multi-slice CT scan of the polytrauma patient is the gold standard now. So this is the gold standard, that you do the CT scan of the body, maybe head, chest, abdomen, pelvis, to rule out any internal bleeding or trauma which can be life-threatening. An X-ray of the spine and the long bones now come in the secondary survey. So what is the delayed primary surgery? So what is the delayed primary surgery on day one? Day one, definitely it is not basically the delayed primary surgery. It is basically On day one, it is a damage control surgery. So it may include decompression of the compartment extremities and spinal stenosis due to vertebral fracture. The compartments of the body, the upper limb, the lower limb, because after the trauma, the muscle starts to swell up and they can cause compartment syndrome in the limbs, or the fractures of the spine can cause can encroach on the spinal canal and cause spinal stenosis, which are medical emergencies or surgical emergencies, what to say. So you have to decompress the compartments and remove the stenosis of the vertebral fractures. Laparotomy for hollow viscous injuries. Yes, in abdomen, if you get a fast positive or there is a CT scan in which you can see that there is some collection in the body or the abdomen, you have to do the laparotomy, because the hollow viscous injuries, the viscous are damaged, there is blood bleeding or the fluid coming out, and you have to go and repair it. Vascular repair, definitely vascular repair is the key to survival of any limb or life of the patient. You have to do it as a damage control strategy. Debridement of wounds and open fractures. Yes, the earlier the debridement of the wounds and open fracture, the less chances of the patient going into infection of these areas. There is a less chance of the patient having infection of these areas. So you have to debride the wounds and open fractures. Okay, if there are fractures, so you cannot do a definite surgery of nailing or plating. So what do? You do an external fixation of the fracture of the long bones. You fix the bones by external fixator and then go for it. Dorsal fixation of the unstable vertical fractures, vertebral fractures. You have to fix all those unstable fractures because they can anytime cause the spinal canal to get stenosed and the paralysis can ensue. All these surgeries, the aforementioned surgeries, should take as little time as possible to avoid an iatrogenic second hit, because you are doing the surgery is a second hit. The lesser the time you take, the lesser the hit there is, and the most of a chance of the patient. So intensive care and schedule for definite surgery of the patient. So the team leader must be the anesthetist, because the patient is in a trauma. The patient has polytrauma. He must be admitted in ICU for optimum care and stabilization of the patient. What are the endpoints when you see that the patient is now improving and the first hit or the trauma phase is ending up? So there are stable hemodynamics without the need of vasoactive and inotropic support. The hemodynamics must be secured without the need for any drips or any medicines. No hypoxemia or hypercapnia. The lungs are functioning normally. There is normal exchange of gases in the lungs. Serum lactate less than 2 millimole per liter. That is the microcirculation is going on, and that is doing well. There is normal coagulation. The coagulopathy has subsided because the trauma causes coagulopathy, and it can be a cause of death. Normothermia, the patient is maintaining his temperature on its own, and the urine output must be greater than 1 milliliter per kg per hour. So that shows that the kidneys are also being perfused. So all these things are endpoints of the resuscitation. When all these things are achieved, the resuscitation is complete or success. The pathophysiological phase of hyperinflammation. So the day 2 to day 4 after trauma, no surgery. We do not operate on from day 2 to day 4 especially, because there is an enhanced susceptibility to the second hit. The patient is recapturing from the first hit, the trauma, and if you do go for a surgery within the first week, or like especially from day 2 to day 4, the patient can sustain life-threatening second hit. Window of opportunity from day 5 to day 10. This is the time when the effect of the first hit has subsided. So this is a window of opportunity from day 5 to day 10. You can plan a definite surgical procedure during this period, because this is the period when the body is stable and you can perform your surgery as you like. Then starts the phase of immunosuppression. What happens in immunosuppression? It starts from the second week to third week. This is an immunosuppression phase because the hit has caused the secondary inflammatory markers to release, and then the body is in stress. So it is now recovering from that stress. So all the white blood cells and all the immunosuppressive things are busy over there. So they start the immunosuppression phase starts from the second week. During this, definitely you cannot do surgery. No surgery, because there is a high susceptibility infection when the patient is immunosuppressed. If you do surgery, you can get the patient infected, and this infection can be life threatening. And then also the second hit, because when there is immunosuppression, there is uh, no way the body can fight from the second hit of the patient, and the second hit can prove fatal. 4 weeks and onwards, obviously, all major reconstruction, the body has recovered well up to previous pre-trauma levels, and all major reconstruction procedures can be done by that. So this is how you deal with the patient. Thank you. Any questions? Huh? Yeah. Which is can be used to review this lecture. Okay. तो तारिक मैं वॉइस में बता दूं. अच्छा, तो there is a question I have got. Okay. Thank you, Sona. You are most welcome. Which resource can we use to review this? There are many resources. You can go online. There is ATLS books, wide range of ATLS books over there. So there are many resources over there. What is meant by second? Okay, second hit. The question from Minha. The second hit basically is that the first hit is the trauma to the patient. The patient the patient's body is hit by trauma. The second hit is means that when you go and operate, you also give stress to the body. You also give a hit to the body. The hit means that the body is under stress of the surgery. There is already a stress of the trauma, and then there is a stress of the surgery also. So you avoid that second hit, because if you go for the second hit, the patient cannot survive such a large amount of stress to the body. Levels of trauma care, could you? Yes, the level of care, trauma care is definitely there are level 1, level 2, level 3. The level 3 is the place where every thing about trauma you can do. Level 1 is just at the site of the injury, or at that level where some life-saving things are present, but you cannot go for some reconstructive surgeries. Level 2 is more advanced than that, and level 3 is completely over there, so that you can manage all the things over there. So these are different levels of the surgeries and trauma care over there. Okay, thank you.